Anatomical considerations of the mitral valve are important while considering mitral valve repair either surgically or by percutaneous transcatheter techniques. The mitral valve complex consists of the mitral annulus, mitral valve leaflets, the chordae tendineae and the papillary muscles. The mitral leaflets are the anterior and posterior leaflets. The posterior leaflet has three scallops named P1, P2 and P3. The commissures of the mitral valve are the anterolateral and the posteromedial commissures. The papillary muscles are the anterolateral and the posteromedial papillary muscles. P1 scallop is near the anterolateral commissure and the P3 scallop near the posteromedial commissure with the P2 scallop in the middle. As P1 scallop is near the anterolateral commissure, it is known as the anterolateral scallop or lateral scallop. P3 scallop is near the posteromedial commissure and is known as the posteromedial scallop or medial scallop. P2 is known as the central scallop. Professor Alan Carpentier was one of the pioneers in mitral valve repair who introduced the nomenclature of mitral scallops. Normal mitral valve in parasternal short axis view. RV right ventricle, IVS interventricular septum, AML anterior mitral leaflet, PML posterior mitral leaflet, LVPWO left ventricular posterior valve. 2 indentations and 3 scallops of posterior mitral leaflet are seen. Though the anterior leaflet does not have well-defined scallops like the posterior leaflets, there are corresponding named segments known as A1, A2 and A3. The chordae tendineae are of 3 types: primary, secondary and tertiary. Primary chordae attach to the tips of the mitral leaflets, while the secondary chordae connect the rough zone of the leaflets to the papillary muscles. The secondary cords are also known as strut cords. The tertiary chordae are attached to the basal region of the mitral leaflets and connect to the ventricular free wall. The tensing of the chordopapillary system during systole has an important role in the competence of the mitral valve in preventing regurgitation. This is a discussion on the assessment of mitral valve area by echocardiography using multiple methods. Though mitral valve area by echocardiography can be measured by multiple methods, commonly used ones are two-dimensional planimetry of valve area and pressure half-time methods because of their ease of performance. In two-dimensional planimetry, the valve area is traced out using an electronic caliper and the machine calculates the valve area. Smallest full circle is taken as the mitral valve area, as larger full circles may be proximal measurements of the belly of the mitral leaflets and hence not representative of the actual severity of obstruction. If it is not full circle, it may be a distal measurement or oblique measurement. Mitral valve area by planimetry on echocardiogram is usually obtained from the parasternal short axis view. It can also be obtained from the basal transgastric short axis view by transesophageal echocardiography. The inner edge of the leaflets is traced in mid-diastole. Gain setting should be optimized as high gain settings can underestimate the valve area. Two-dimensional valve area measured in this way gives an overestimate compared to that measured by three-dimensional echocardiography, especially in those with dilated left atrium. This is because better alignment at the tip of the mitral valve can be obtained by transesophageal 3D echo with excellent inter-observer and intra-observer reproducibility. 3D planimetry from the left ventricular aspect is the most accurate method of measurement of mitral valve area. Measurement of mitral valve area after balloon mitral valvotomy follows the same pattern. Measurement using real-time 3D echocardiography is superior to 2D planimetry of mitral valve area in the immediate post-mitral valvotomy period. Real-time 3D echocardiographic valve area has the best correlation with invasively determined mitral valve area in this setting. Assessment of mitral valve area by pressure half-time involves Doppler echocardiography. A pressure half-time of 220 millisecond corresponds to the valve area of 1 square centimeter. Pressure half-time is measured from the descent of the E wave in the transmitral Doppler usually obtained in apical 4-chamber view. PHT is the time taken for the peak transmittal gradient to fall to half its value. It will also correspond to the time taken for the transmittal velocity to fall by square root of 2, as the pressure gradient is proportional to the square of the velocity. Mitral valve area is equal to 220 by pressure half time. In this image, green cursor measures the pressure half time of the mitral stenosis jet. In this case, the pressure half time was 163 milliseconds and the estimated mitral valve area by pressure half time was 1.3 square centimeters. Smith and colleagues have shown that both two-dimensional planimetry and pressure half time methods give good estimate of mitral valve area non-invasively. They found that pressure half time method is superior to two-dimensional planimetry to assess mitral valve area in those who have undergone mitral commissurotomy. It has been shown that associated aortic regurgitation shortens the transmitral pressure half time, thereby leading to overestimation of mitral valve area by Doppler echocardiography. An earlier study had shown that mitral regurgitation does not significantly change the estimation of mitral valve area by pressure half time method. Continuity equation uses mitral and aortic flow as well as cross-sectional area of the left ventricular outflow tract to derive the mitral valve area. The area is measured by planimetry and flow measured by Doppler assessment of velocity time integral. Proximal isovelocity surface area or PISA method utilizes the flow convergence region proximal to the high velocity transmittal jet in diastole. PISA is the surface area of the hemisphere at the aliasing region of the flow convergence. PISA increases as the flow increases and with lower aliasing velocity. To reduce errors in measurement, smaller aliasing velocity must be set to get higher PISA measurement with lower chance for errors. If the flow convergence is not a true hemisphere, the angle subtended by the flow convergence at the orifice must be measured and divided by 180 to get a correction factor. The diastolic flow rate is calculated as follows. Mitral flow is equal to 2 pi r squared into angle alpha divided by 180 into aliasing velocity. R is the maximal radius of the flow convergence region in early diastole measured on the central line of the flow convergence region. V alias, aliasing velocity, alpha by 180, correction factor accounting for the angle alpha between the mitral leaflets. Mitral valve area is then determined by dividing maximal diastolic flow rate by peak continuous wave Doppler velocity of mitral inflow, that is Vmax. PISA method is based on the same principle as the continuity equation. It has been shown to be accurate and reproducible. Proximal flow convergence can be easily visualized. Wilkins echocardiographic score for mitral stenosis. Wilkins echocardiographic score for mitral stenosis is useful for deciding whether the valve is suitable for balloon mitral valvotomy. The score was developed based on the first 22 patients who underwent balloon mitral valvotomy at their center. 4 parameters considered in Wilkins score are leaflet mobility, leaflet thickening, leaflet calcification, and subvalvular apparatus. Each parameter is graded 1 to 4 depending on the severity. Total score possible is 16. A score up to 8 is considered ideal for BMV. When the score is higher, the chance of significant mitral regurgitation as a complication of BMV is more likely. Regarding mobility, in grade 1, leaflet is highly mobile with only leaflet tip movement restricted. In grade 4, there is minimal or no movement. Other grades are in between. On the thickness aspect, leaflet thickness is near normal 4 to 5 mm in grade 1. In grade 4, there is considerable thickening of whole leaflet 8 to 10 mm or more. Grade 2 and 3 are in between. In grade 1 for calcification, there is only a single area of echo brightness. In grade 4, there is extensive brightness throughout most of the leaflet tissue. Intermediate grades are in between. Grade 1 for subvalvular thickening is just a single area of increased echo brightness. In grade 4, there is extensive thickening and shortening of all caudal structures down to the papillary muscles. Patterns in between are seen for other grades. Various other 2D echo-based scoring systems have been proposed later for the assessment of the mitral valve. These were Chen score, Reed score, Nobuyoshi score and Cormier score. With the onset of 3D echocardiography, scores based on 3D echo has also been proposed. 3D grading might overcome the difficulty in differentiating between calcification and nodular fibrosis. When the diastolic murmur is not audible despite the presence of severe mitral stenosis, it is called silent mitral stenosis. Mechanism and causes of silent mitral stenosis. Right ventricular hypertrophy causes clockwise rotation of the heart so that left ventricle becomes more posterior and the apex is formed by the right ventricle. Hence, the diastolic murmur of mitral stenosis is not heard at the apex. Another reason is the decreased flow across the mitral valve in very severe mitral stenosis, diminishing the intensity of the murmur. The decreased mobility of the thick and calcified mitral leaflets in severe calcific mitral stenosis may contribute to the decrease in intensity of mitral diastolic murmur. Guttmacher syndrome, pulmonary emphysema, and obesity are other possible causes for silent mitral stenosis. Severe tricuspid stenosis is another cause of silent mitral stenosis. In this case, even the transmitral gradient may be low despite having severe mitral stenosis. Transmitral gradient may be lower than expected for the severity of mitral stenosis in Guttmacher syndrome. Due to the associated large atrial septal defect, gradient between left and right atria is reduced. Hence, the left atrial pressure is lowered and consequently the transmitral gradient. But the left-right shunt across the AST will be high. In emphysema and obesity, the murmur of mitral stenosis may be inaudible due to poor transmission from the heart to the stethoscope. In emphysema, air intervenes while adipose tissue intervenes in obesity. Murmur audibility may improve on auscultation in held expiration in the left lateral position. Silent MS can present as pulmonary hypertension with right heart failure or with Ortner syndrome due to compression of the left recurrent laryngeal nerve by massively dilated left atrium or pulmonary artery. Ortner syndrome presents with hoarseness of voice. Discussion on mitral valve calcification noted on chest X-ray and mitral annular calcification with calcific mitral stenosis. X-ray chest PA view showing mitral valve calcification in severe rheumatic calcific mitral stenosis. The structures marked are as follows. 1. Aortic knuckle with intimal calcification known as first Mughal. 2. Prominent main pulmonary artery segment known as second Mughal. 3. Prominent left atrial appendage known as third Mughal. 4. Calcification of mitral valve. 5. Elevated left bronchus, feature of left atrial enlargement. 6. Double atrial contour, border of enlarged left atrium, shadow within shadow. 7. Right atrial border shifted to right, suggestive of right atrial enlargement. In addition, left pulmonary artery can be seen descending from the main pulmonary artery within the cardiac shadow. Medial to that, the descending aorta can be seen to the left of the spine. Right pulmonary artery is also seen as a prominent structure descending from the right hilum. Upper lobe vessels are also a little prominent. Calcification of the mitral valve is seen only rarely these days, as most persons with rheumatic mitral stenosis get operated before the valve becomes severely calcified. Only long-standing cases unfit for surgery due to other reasons can be noted to have such dense calcification on chest X-ray. Calcification on fluoroscopy and echocardiography can be seen more often. Left coronary angiogram showing calcification of aortic and mitral valves. LAD, left anterior descending coronary artery. LCX, left circumflex coronary artery. OM, obtuse marginal branch of left circumflex coronary artery. Right coronary angiogram showing mid-RCA lesion as well as calcification of aortic and mitral valves. Mitral valve is located below and to the left of the line joining main pulmonary artery segment to the right cardiophrenic angle. Aortic valve is located above and to the right of this line. So calcifications and prosthetic valves in these locations can be identified with reference to this line in mind. Generally, calcification of mitral valve was part of rheumatic heart disease with long-standing mitral stenosis. But rheumatic mitral stenosis is gradually becoming a rarity with lower prevalence of rheumatic fever and its sequelae. Mitral annular calcification can extend to the base of the mitral leaflets, especially the posterior leaflet, and cause a gradient across the mitral valve. This form of mitral stenosis is distinct from rheumatic mitral stenosis. It has been called calcific or degenerative mitral stenosis. Risk factors for mitral annular calcification are advanced stage, female gender, and end-stage renal disease. In rheumatic mitral stenosis, maximum narrowing is at the leaflet tips and associated with commissural fusion. In mitral annular calcification with mitral stenosis, the predominant narrowing is at the base of the mitral valve leaflets. Discussion on prosthetic mitral valve echocardiogram. Evaluation of prosthetic valves is one of the difficult tasks in echocardiography because of the dense shadows caused by prosthetic valves. It may be virtually impossible to detect small lesions like a vegetation on the far side of the prosthetic valve. At the same time, a prosthetic valve endocarditis has a much more dismal prognosis than a native valve endocarditis. Moreover, even normally functioning prosthetic valves may have a gradient across, which would be considered abnormal for a native valve. Echocardiogram of prosthetic mitral valve in parasternal long axis view showing the valve in the closed position and the aortic valve in the open position. The metallic component of the prosthetic valve produces dense echoes. The left atrium is dilated, possibly a sequelae of the old lesion for which the mitral valve was replaced. The aorta is relatively small and left ventricle is of normal size, indicating that the lesion could have been mitral stenosis. When a prosthetic valve is placed in a case of isolated mitral stenosis, especially one of the caged valve variety with a high profile, the cage will jut into the left ventricular outflow tract and may increase the LV outflow gradient. This picture shows the prosthetic mitral valve in the open position. See the dense acoustic shadowing behind the valve, which obviously can obscure small vegetations in that region. Getting a transesophageal echo is a way to look at the far side of the prosthetic valve when an endocarditis is suspected clinically. In transesophageal echocardiography, since the transducer is behind the left atrium, the atrial aspect of the prosthetic valve can be imaged without interference by acoustic shadowing. Apical four-chamber view is also useful in the evaluation of the prosthetic mitral valve. Acoustic shadowing is a problem in this view also. An M-mode cut of the prosthetic mitral valve is useful in documenting the poppet excursion. Poppet excursion is diminished in case of thrombus or pannus formation. Thrombus formation usually presents with acute mitral valve obstruction while pannus formation presents more insidiously with increasing gradients and effort intolerance. Color Doppler imaging from the apical four-chamber view shows normal antegroid flow and a trivial backflow which is normal during the closing movement of the prosthetic wall. This view is also useful to look for paravalvular and transvalvular leaks. Early onset of paravalvular leak may indicate the giveaway of a surgical suture. Doppler interrogation from this view is useful in quantifying the transvalvular gradients. It is always good to document the gradients serially to identify rise in gradients due to pannus formation. Acute obstruction usually presents with pulmonary edema due to grossly elevated pulmonary venous pressures and calls for urgent intervention. Stent creep seen in some types of bioprocesses is due to inward bending of the stent struts. It may not be obvious on two-dimensional echocardiographic imaging, but increases the transvalvular gradient as measured by Doppler echocardiography. Stent creep tends to increase with time after implantation. It was due to an ultrastructural deformity of polypropylene used in the valve stent. This was noted in explanted Hancock bioprosthesis, which led to the development of newer stent materials resistant to such deformity. Valve-in-valve transcatheter aortic valve implantation has been used to treat bioprosthetic failure due to stent creep. They reported 3 cases. 2 had Carpentier-Edwards Perimount prosthesis. 1 had mitral flow. Others suggested that valve oversizing could be the reason for permanent inward deflection of stent posts. 3-dimensional echocardiographic geometric analysis has been used for analysis of failed bioprosthesis to determine stent creep. 3 stent posts are used in bioprosthetic valves to provide support to the leaflets. These stent posts are perpendicular to the annular plane and situated at the corners of a bottom triangle. The tips of the posts are also at the corners of a top triangle. Normally, the areas of both these triangles are equal. When stent creep develops, tip triangle shrinks due to inward bending of the stent posts. With stent creep, the ratio between the top and the bottom triangles, known as stent creep ratio, becomes less than 1. This can be measured by 3D echo and gives an assessment of stent creep non-invasively. Finally, a few words about mechanical valve malfunction. Mechanical valve malfunction could be due to ball degeneration, ball variance, strut fracture, thrombus or pannus. Pannus is the growth of fibrous tissue into the valve structure resulting in increase of transvalvular gradient. Discussion on causes of elevated prosthetic valve gradients. Elevated gradients across prosthetic valves can occur due to various reasons. But before declaring that prosthetic valve gradients are elevated, the usual gradient across the given type of prosthetic valve should be known. Different types of normally functioning prosthetic heart valves have different gradients. Normal gradient is different between the various valve positions. Transmitral prosthetic valve gradient is lower than transaortic prosthetic valve gradient. If the gradient during postoperative review is available, it can be used as a benchmark for comparison. Some of the important causes for elevated prosthetic valve gradients are prosthetic valve thrombus, pannus, large vegetations, calcific degeneration of bioprosthetic valve, patient prosthesis mismatch, high output state, pressure recovery phenomenon, and high velocity central flow in a bileaflet valve. Clinical scenario should be considered in detail during evaluation of elevated gradients, as echocardiographic patterns have their own limitations in the assessment of prosthetic valves. Body surface area should be checked while assessing patient prosthesis mismatch. Elevated transprosthetic gradient is an important feature of thrombus within the prosthetic valve. In the mitral position, a gradient more than 8 mm of mercury is suggestive of prosthetic valve thrombosis. In case of aortic prosthetic valve, the suggested cutoff value is more than 45 mm of mercury. A word of caution is needed here in that gradients may be low in low output state despite significant obstruction. This has been called silent Doppler prosthetic valve thrombosis. Pannus formation or tissue growth into the prosthetic valve can increase the transvalvular gradients. An in vitro study has shown that when the pannus width was 25% of the valve diameter, gradient can be increased more than 2.5 times than without pannus. Large vegetation has been mentioned as a very rare cause of prosthetic valve obstruction. Large vegetations are a feature of fungal endocarditis and staphylococcal endocarditis. Calcific degeneration can occur in glutaraldehyde preserved bioprosthetic valves. This is yet another cause of increased transprosthetic valvular gradient. Patient prosthesis mismatch is important mostly in the case of aortic valve. When the aortic valve is replaced for aortic stenosis, aorta may be small and may take only a relatively smaller prosthesis. Aortic root widening procedures are done sometimes but can increase the surgical risk. Patient prosthesis mismatch can be assessed by checking the body surface area and the corresponding size of the prosthetic valve. Severe patient prosthesis mismatch is defined as indexed effective orifice area less than 0.65 square centimeter per square meter body surface area. As we have seen low gradient with low output state, higher gradient can occur in high output state. This aspect should be considered before considering an elevated prosthetic valve gradient as being due to obstruction of the valve. Pressure recovery phenomenon can impact the Doppler assessment of prosthetic valve performance. Pressure recovery phenomenon is recovery of aortic pressure beyond the region of the jet across the aortic valve. The lower pressure near the valve is due to the effect of the jet, which causes a reduction in the lateral pressure. To get the recovered pressure or settled pressure, catheter has to be pulled back about 2 to 3 cm beyond the sinotubular junction. The lower pressure near the valve gives a falsely elevated transaortic valvular gradient when measured by Doppler echocardiography. High velocity jet through a relatively narrower central orifice of a bileaflet prosthetic valve can produce a falsely elevated gradient. This was noted on catheter pullback through the central orifice, while it was not there on pullback through the side orifices. The mean difference between the central and side orifices was 46%. This value corresponded to the elevation in Doppler gradient. It was an in vitro study in an aortic valve pulsatile model. Discussion on echocardiographic assessment of patient prosthesis mismatch. Patient prosthesis mismatch is present when the effective prosthetic valve area is less than that of the normal human valve. The reduction in valve area is usually mild to moderate and may not be of immediate clinical significance. Occasionally, it can be severe and patients may be hemodynamically and symptomatically worse after valve replacement. This typically occurs after aortic valve replacement for aortic stenosis, as the aortic annulus is not dilated and permits insertion of only a smaller prosthetic valve compared to that in aortic regurgitation. Similar situation can be there after mitral valve replacement for mitral stenosis. Patient prosthesis mismatch is an important cause of increased transvalvular gradient detected by Doppler echocardiography. Effective orifice area of an aortic prosthetic valve may be too small in relation to patient's body surface area and can result in abnormally high gradients. Indexing of calculated valve area with respect to body surface area is usually done to assess patient prosthesis mismatch. Indexed effective orifice area of an aortic prosthetic valve should be more than 0.85 square centimeter per meter squared to avoid significant gradient at rest and exercise. This corresponds to the concept that in moderate stenosis of native aortic valve, the indexed effective orifice area is less than 0.9 square centimeter per meter squared. An indexed effective orifice area less than or equal to 0.6 square centimeter per meter squared will correspond to severe stenosis and requires reoperation. Effective orifice area is usually calculated using continuity equation and involves two-dimensional and Doppler echocardiography. Effective prosthetic orifice area is equal to cross-sectional area of the left ventricular outflow tract into velocity time integral of the left ventricular outflow divided by velocity time integral of aortic jet. The cross-sectional area of left ventricular outflow tract can be calculated from the diameter measured by two-dimensional echocardiography or the documented diameter of the sewing ring of prosthetic valve. A simplified method for calculation of effective orifice area is cross-sectional area of left ventricular outflow tract into peak velocity of left ventricular outflow divided by peak velocity of aortic jet. In case of mitral valve replacement, an indexed effective orifice area less than 1.2 square centimeter per meter squared is considered as patient prosthesis mismatch. Mitral patient prosthesis mismatch has been classified as moderate if indexed effective orifice is more than 0.9 and less than or equal to 1.2 square centimeter per meter squared, and severe if less than or equal to 0.9 square centimeter per meter squared. Buccal tracking echocardiography has been used to assess patients with severe patient prosthesis mismatch. They defined severe patient prosthesis mismatch after aortic valve replacement as indexed effective orifice area of 0.65 square centimeter per meter squared or less. They found that global longitudinal strain and global circumferential strain was significantly decreased in the 54 patients with severe patient prosthesis mismatch, suggesting subclinical left ventricular dysfunction. These patients had preserved left ventricular ejection fraction. Three-dimensional and transesophageal echocardiography can be used to get better measurements of the left ventricular outflow tract diameter compared to transthoracic echocardiography. Outer margin of the stent or cage of the prosthetic valve should be measured. While assessing transprosthetic velocity by continuous wave Doppler, multiple windows including apical and right parasternal views should be used. For measurement of left ventricular outflow velocity, pulse wave Doppler sample should be placed immediately below the apical border of the stent with no valve opening or closing clicks visible. Discussion on indications for surgery in prosthetic valve endocarditis also covers the concept of biofilm in infective endocarditis. Prosthetic valve endocarditis is a life-threatening situation and often can be refractory to medical therapy, requiring surgical intervention. Indications for surgery in prosthetic valve endocarditis include the following. 1. Persistent bacteremia after 7 to 10 days. 2. Heart failure. 3. Early prosthetic valve endocarditis. 4. Fungal endocarditis. 5. Paravalvular leak. 6. Annular or aortic abscess. 7. True or false aneurysm. 8. Fistula formation. 9. New onset conduction disturbance. 10. Recurrent peripheral embolization despite therapy. A best evidence topic review suggested that unless patient is a poor surgical candidate, surgery is the treatment of choice in prosthetic valve endocarditis. They recommended early surgery if there is hemodynamic instability, heart failure, valvular dysfunction, dehiscence, or annular abscess. In addition, they recommended early surgery for prosthetic valve endocarditis due to Staphylococcus aureus. PALSU score has been developed by Spanish collaboration on endocarditis to predict in-hospital prognosis for valve surgery in endocarditis. PALSU score parameters are prosthetic valve, age 70 years or more, large intracardiac destruction, staphylococcus, urgent surgery, female gender, and a Euro score of 10 or more. They noted a mortality rate of 45.4% in patients with PALSU score above 3. Even though heart failure is an important reason for urgent surgery in prosthetic valve endocarditis, it need not indicate a bad prognosis. Large vegetations and uncontrolled infection are considered the main factors associated with high in-hospital mortality in those undergoing urgent surgery. In-hospital mortality was 41% in this series, with 46 patients having left-sided infective endocarditis. 35% in-hospital mortality for surgery in prosthetic valve endocarditis has been reported by Rekic and colleagues. Most organisms causing infective endocarditis can produce a nearly impenetrable barrier around them called a biofilm. Biofilm is an extracellular polysaccharide slime-like matrix which can protect the organisms from the host immune mechanisms. It also impedes the efficacy of antimicrobial agents due to poor penetration. Surgery for prosthetic valve endocarditis mechanically disrupts the biofilm and exposes the viable microorganisms to antibiotics and the host immune system. In addition to this, surgery also removes infected tissue and foreign material. A full course intravenous antimicrobial therapy is needed after surgery for complete clearance of the organisms. Vegetation on tricuspid valve, flail septal tricuspid leaflet, and severe tricuspid regurgitation. Vegetation on tricuspid valve seen on echocardiography from a modified apical four-chamber view. LV left ventricle, LA left atrium, RV right ventricle, RA right atrium. In live echo imaging, the vegetation will show a motion pattern independent of the movement of the tricuspid leaflet. Tricuspid valve endocarditis with vegetation is seen in intravenous drug users or occasionally in those with a central venous catheter in situ for a long period. A similar situation is a transjugular hemodialysis catheter. When a catheter is associated with vegetation, the catheter is usually removed and the tip sent for culture. Blood cultures as per standard protocol are also taken along with it. Tricuspid valve vegetations can embolize into the pulmonary circulation, leading to septic pulmonary embolism. Song and associates noted in their retrospective study of 20 cases of cardiac septic pulmonary embolism that there were right-sided vegetations in 15 cases. Repeat echo at a later date after antibiotic treatment showed regression of vegetation and a flail septal tricuspid leaflet pointing towards the right atrium. Flail leaflet is a result of rupture of the chordae tendineae and causes tricuspid regurgitation. Severe tricuspid regurgitation seen as a bluish mosaic multicolored jet from the right ventricle to right atrium in systole. The mitral valve can be seen in the closed position between the left ventricle and left atrium, indicating that it is a systolic frame. Discussion on rheumatic mitral regurgitation. Though most of the manifestations of acute rheumatic fever do not leave long-lasting sequelae, carditis is different. Carditis can resolve without any sequelae in a few cases, but most often it leads to valvular lesions which are progressive. The most commonly involved valve is the mitral valve, and mitral regurgitation is the commonest lesion in acute rheumatic fever. Stenotic lesions do not occur in the acute phase as they take a long time to develop by progressive fibrosis. According to Paul Wood, the frequency of involvement of the valves in rheumatic fever is related to the hemodynamic load on the valve. In this respect, mitral valve has the maximum load, followed by aortic, tricuspid and pulmonary in that order. Hemodynamic load on the mitral valve is the left ventricular systolic pressure, while that on the aortic valve is the aortic diastolic pressure. The load corresponds roughly to the distal pressure when the valve is closed. Mitral valve is the commonest valve involved in rheumatic heart disease. Mitral regurgitation occurs in the early phase of acute rheumatic fever itself. In fact, it is almost an invariable association of rheumatic carditis. In very early stages of rheumatic carditis, MR may be clinically silent but demonstrable by Doppler echocardiography. Some studies have shown that Doppler echocardiographic detection of MR in the acute phase of rheumatic carditis predates clinical detection by up to 2 weeks. Many of the cases of MR due to rheumatic carditis resolve later or decrease in severity on follow-up. Even though the carditis in rheumatic fever is a pancarditis, the predominant involvement is that of the endocardium in the form of valvular involvement. Hence, the mechanism of mitral regurgitation in the acute phase is mainly valvular and seldom due to left ventricular dilatation secondary to myocarditis and left ventricular failure. But significant MR itself can set up a vicious cycle because left ventricular dilatation caused by MR can further increase the MR. This is by dilatation of the mitral annulus, which decreases the coaptation of mitral leaflets in systole. This is known as MR begets MR. Clinically, chronic rheumatic MR is associated with a forceful left ventricular apical impulse, cardiomegaly, soft first heart sound, left ventricular third heart sound, and an apical pansystolic murmur which is conducted to the axilla. Conduction to the axilla differentiates the murmur of rheumatic MR from the murmur of MR due to papillary muscle dysfunction. Murmur of MR in papillary muscle dysfunction is usually conducted to the base of the heart. This is because anterior mitral leaflet is involved more in rheumatic MR and the jet is directed posteriorly. Posterior papillary muscle is more commonly involved and the jet is directed anteriorly in ischemic papillary muscle dysfunction. Echocardiogram showing posteriorly directed MR jet in rheumatic heart disease. Sometimes a late systolic pulsation of the left parasternal region due to the expansion of the left atrium may also be felt. ECG may show PR interval prolongation in the acute phase of rheumatic MR with carditis. In chronic rheumatic MR of significant severity, ECG shows left atrial and left ventricular enlargement. Chest X-ray shows cardiomegaly and left atrial enlargement in severe rheumatic MR. Pulmonary congestion and features of pulmonary hypertension may occur in late stages. Pulmonary congestion and cardiac failure can also occur in the acute phase if the rheumatic carditis is fulminant. Echocardiography shows thickening of the mitral leaflets and tethering of the posterior mitral leaflet with restriction of movement. But frank reversal of movement, that is paradoxical anterior movement of the posterior leaflet in diastole as in mitral stenosis, does not occur in isolated rheumatic MR. Immobility of the posterior leaflet is the hallmark of rheumatic mitral regurgitation, which differentiates it from non-rheumatic mitral regurgitation on echocardiography. Systolic separation of the mitral leaflets can be seen sometimes. Dilated left atrium and left ventricle gives a suggestion that the MR is significant. Doppler echocardiography is needed to confirm MR and quantify it. The intensity of the spectral tracing and the depth to which the jet is located by pulse Doppler is an indication of severity of MR. By color Doppler, the area of the jet in relation to the left atrium determines the severity. The depth to which the jet reaches in the left atrium is also an important determinant of severity. According to the World Heart Federation criteria, morphological features of rheumatic mitral valve involvement on echocardiography are: 1. Anterior mitral leaflet thickening of 3 mm or more, 2. Caudal thickening, 3. Restricted leaflet motion, 4. Excessive leaflet tip motion during systole. Unlike the mitral valve in non-rheumatic MR, the heavily scarred mitral valve in rheumatic MR may not always be suitable for a conservative mitral valve repair procedure. Very often, they end up in mitral valve replacement if severe enough to produce symptoms or impairment of left ventricular function. Discussion on rheumatic aortic regurgitation. Rheumatic aortic regurgitation can occur in the acute phase of rheumatic fever and disappear later. In the chronic stage, it may progress in severity. Peripheral signs of aortic regurgitation are noted in chronic severe aortic regurgitation due to the rapid aortic runoff along with peripheral vasodilatation. Peripheral resistance is reduced in an attempt to reduce the regurgitation and encourage forward flow. High volume collapsing pulse is characteristic of severe aortic regurgitation. Echocardiogram from parasternal long axis view showing the high velocity mosaic colored aortic regurgitation jet from aortic valve into the left ventricle. Both left atrium and left ventricle are dilated in severe aortic regurgitation. Initially, the left ventricle dilates and tries to accommodate the regurgitant volume. In addition to dilatation, there is hypertrophy of the left ventricular wall. This is known as eccentric left ventricular hypertrophy. As time passes, this compensatory mechanism fails and the left ventricle starts failing. Left ventricular muscle can develop fibrotic changes which indicate irreversible late-stage disease. Clinical findings in aortic regurgitation include high volume collapsing pulse, cardiomegaly with a forceful apex, and a high-pitched blowing early diastolic murmur heard in the aortic area and along the left sternal border. A mid-diastolic or pre-systolic murmur in the mitral area due to flow across a functional narrowing of the mitral valve in aortic regurgitation is known as Austin-Flint murmur. Peripheral signs of AR are mostly due to the high stroke volume and high pulse pressure. They are noted in severe AR. These are features of aortic runoff and can occur in other situations of aortic runoff like ruptured sinus of Valsalva into right atrium. Peripheral signs of AR have been discussed in another video on this channel. As the prevalence of rheumatic heart disease is declining, we have to go back to previous studies for the natural history of rheumatic heart disease. One such study from 1971 reported data on 174 young patients with aortic regurgitation followed prospectively for a median period of 10 years. 31 patients developed the triad of moderate or marked left ventricular enlargement, 2 or 3 ECG abnormalities, and abnormal blood pressure. 1/3 of these patients either died or had heart failure or angina within 1 year. 48% had these endpoints in 2 years, while 65% had it in 3 years, and 87% in 6 years of having the triad of findings. 71 patients with none of these features had uneventful courses. Among the patients with 1 or 2 of the features among the triad, only 7 either died or became symptomatic. Another study published in 1976 reviewed 180 patients with severe aortic regurgitation. 110 of these patients underwent aortic valve replacement. Among the 39 clinical and hemodynamic parameters studied, only heart failure, radiographic heart size, left ventricular hypertrophy, and ventricular premature beats were associated with death before surgery. Preoperative factors associated with an unfavorable result after surgery were advanced heart failure, cardiomyopathy, extreme cardiomegaly, and left ventricular premature beats. Discussion on eccentric aortic regurgitation jet or eccentric AR. Eccentric jet of aortic regurgitation coursing along the posterior margin of the left ventricular outflow tract on the anterior mitral leaflet. Estimation of severity of eccentric jets may be erroneous, as often the severity tends to be underestimated in case of eccentric jets. AR aortic regurgitation jet, LA left atrium, LV left ventricle, RV right ventricle, AML anterior mitral leaflet. The frame to the right is a systolic frame and the left one is a diastolic frame. The systolic frame shows the mitral valve in closed position while the diastolic frame shows it in the open position. The anterior mitral leaflet shows a reverse doming as the aortic regurgitation jet strikes it. Systolic frame also shows a trivial mitral regurgitation into the left atrium just behind the mitral valve as a bluish mosaic jet. Measurement of vena contracta or the width of the proximal regurgitant jet for grading of aortic regurgitation becomes unreliable when the jet is eccentric. In central jets, a jet width less than 0.3 cm is highly specific for mild AR, and a width more than 0.6 cm is highly specific for severe AR. Eccentric aortic regurgitation has been described in patients with right coronary cusp prolapse complicating a ventricular septal defect. In a study of 129 patients, 27 had moderate aortic regurgitation. Of these, 14 had eccentric aortic regurgitation jet. One of the patients who had mild aortic regurgitation initially had eccentric jet when it progressed to moderate AR. 5 of the 9 patients with mild eccentric AR jets progressed to moderate eccentric AR jets. At the same time, only 7 of 105 who had mild central AR progressed to moderate AR. The authors concluded that eccentric AR is highly likely to progress and is malignant. Eccentric aortic regurgitation has been reported in ascending aortic aneurysm. As the usual assessment of severity was erroneous, proximal isovelocity surface area method had to be used for quantification of aortic regurgitation. Discussion on important aspects of acute aortic regurgitation. Hemodynamics and findings in acute aortic regurgitation are significantly different from the familiar picture of chronic aortic regurgitation. Due to the atypical findings, it may be difficult to diagnose acute aortic regurgitation. All the same, it is not a stable condition like chronic AR. Acute regurgitation can rapidly progress to heart failure and early mortality if left untreated. Important causes of acute AR are infective endocarditis, aortic dissection, and rarely trauma. Rare causes reported are necrotizing granulomatous inflammation of the aortic valve in rheumatoid arthritis, and avulsion of aortic valve commissure and spontaneous rupture of a fibrous strand in fenestrated aortic valve. Pathophysiology of acute AR is characterized by the sudden volume overloading of the left ventricle, which is unprepared and has a normal size. In chronic AR, left ventricle dilates progressively when AR progresses, as the left ventricle gets time to accommodate the additional volume load. In acute AR, there is a rapid increase in LV diastolic pressure, which approaches the aortic diastolic pressure. This causes mitral valve pre-closure in diastole. Premature closure of the mitral valve prevents transmission of elevated left ventricular diastolic pressure to the pulmonary veins and hence pulmonary edema. But when the LV diastolic pressure rises further, this protection is lost and the mitral valve opens in late diastole, causing diastolic mitral regurgitation. Mitral regurgitation can extend to the isovolemic contraction period and early systole when the LV diastolic pressure is very high. Left atrium serves as a reservoir to decompress the left ventricle in acute AR. But this compensatory mechanism can also fail soon when AR progresses, leading to pulmonary edema. Premature closure of mitral valve in acute AR is demonstrated on M-mode echocardiography. Premature mitral valve closure was graded as plus when it occurred before the QRS but after the P wave. When it occurred before the P wave, it was graded as plus plus. These have been called as grade 1 and grade 2 by other authors. Grade 2 premature closure of mitral valve can occur up to 200 milliseconds before the QRS, while grade 1 is up to 50 milliseconds before the QRS. The classical decrescendo early diastolic murmur and peripheral signs of chronic aortic regurgitation are not found in acute AR. An early diastolic murmur, if it is heard, is usually softer and shorter in acute AR. A soft to and fro murmur may be heard in acute AR. Murmur can be absent and the heart sounds quite soft or absent sometimes, leading to a silent precordium. Auscultatory timing of heart sounds are difficult because of their softness and shortening of diastole, often shorter than systole. Systole becomes longer because of prolonged systolic ejection time as the left ventricle is overloaded. Mitral valve closes prematurely and opens late because of prolonged systole. It has been suggested that those with grade 2 premature closure of mitral valve should undergo early aortic valve replacement. Aortic regurgitation in Stanford type A aortic dissection has several mechanisms and they have implications for repair. 5 potential mechanisms are: 1. Incomplete closure of leaflets due to tethering by a dilated sinotubular junction. 2. Leaflet prolapse due to disruption of attachment by dissection flap. 3. Prolapse of dissection flap through the wall leaflets, preventing leaflet coaptation. 4. Bicuspid aortic valve and associated leaflet prolapse unrelated to the dissection process. 5. Degenerative leaflet thickening leading to abnormal leaflet coaptation. First 3 can be considered for repair without replacement of the valve. Discussion on clinical features of severe aortic stenosis. Angina, syncope, and features of heart failure are the important symptoms of aortic stenosis which correlate with survival. The median survival with these symptoms are 5, 3, and 2 years respectively. Angina occurs in aortic stenosis because of a demand-supply mismatch in a hypertrophied left ventricle. Syncope is related to exercise and is due to a relatively fixed cardiac output in the face of systemic vasodilatation which occurs with exercise. Since the cardiac output can hardly increase with exercise in severe AS, cerebral hypoperfusion and syncope results. In degenerative calcific aortic stenosis, which is seen mostly in the elderly, average survival after the onset of symptoms is 2 to 3 years. Patients with syncope, angina and dyspnea need prompt aortic valve replacement. Aortic stenosis is the most common valvular lesion in Europe and North America. The characteristic pulse in severe AS is slow rising, low volume pulse known as pulsus parvus et tardus. A bisference pulse is noted in a combination of aortic stenosis and aortic regurgitation. Bisference pulse has 2 peaks in systole and is more likely to occur in free aortic regurgitation or dominant aortic regurgitation rather than in dominant aortic stenosis. Pulsus alternans has been described in acquired aortic stenosis, but the finding was mostly in left ventricular pressure tracings and the amplitude of variation was much lesser in arterial pressure tracings. It was not seen in congenital aortic stenosis of similar severity in that study. The systolic pressure is low and the pulse pressure is narrow in severe aortic stenosis, but hypertension can occur in degenerative aortic stenosis, particularly in the elderly. In one study, 32% of the 193 patients with symptomatic aortic stenosis had history of hypertension, while the remaining 131 patients were normotensive. The apex is formed by the left ventricle in aortic stenosis, and it is a heaving, that is sustained and forceful apex beat in severe aortic stenosis. In severe AS, the aortic component of second heart sound is soft and delayed. Sometimes even a paradoxical split may occur. Fourth heart sound may be audible due to the forceful atrial contraction needed to improve the filling of a hypertrophied left ventricle. Third heart sound can be heard in left ventricular failure. Systolic thrill is felt in severe AS in the aortic area and over the carotids. A systolic thrill can also occur in lower degrees of aortic stenosis if there is associated aortic regurgitation. The ejection systolic murmur is harsh, loud, long, late peaking, and best heard in the aortic area and conducted to the carotids in severe AS. The murmur may become less audible if the left ventricle fails, and hence severe AS is an important differential diagnosis of dilated cardiomyopathy. When the left ventricular function improves with treatment or inotropic support, the murmur becomes more prominent in severe AS with heart failure. In aortic stenosis of the elderly, the murmur of aortic stenosis is harsh in the aortic area and more musical in the mitral area, resembling associated mitral regurgitation. This phenomenon is known as Galavadin dissociation. It was described by Galavadin in 1925. The harsh murmur in the aortic area is due to turbulent flow across the stenotic aortic wall, and the musical murmur in the mitral area is supposed to be due to the vibration of the left ventricular outflow tract. Galavadin postulated that the high-pitched musical components of the murmur of aortic stenosis were preferentially transmitted to the apex through solid tissues, while lower-pitched components were transmitted to the neck vessels through the blood flow. Giles and associates proposed that the high-pitched musical murmur could be due to associated papillary muscle dysfunction. Aortic stenosis gradient by Doppler echocardiogram. Inset shows a apical 5-chamber view from which the aortic stenosis jet is assessed using a continuous wave Doppler cursor. Aortic stenosis jet moves away from the transducer in this view and is displayed below the baseline. Velocity scale on the right side is in meters per second. Aortic regurgitation jet is seen above the baseline as the regurgitant flow into the left ventricle is towards the transducer kept at the left ventricular apex. AV Vmax, maximum velocity of aortic stenosis jet. AV mean, mean velocity of the aortic stenosis jet. AV max PG, maximum pressure gradient across the aortic wall. AV mean PG, mean pressure gradient across the aortic wall. AV VTI, velocity time integral across the aortic wall. AV NTI, aortic valve envelope time corresponds to the aortic ejection time. HR, heart rate. All gradients are measured in millimeters of mercury, velocities in meters per second, and heart rate in beats per minute. Envelope time is measured in millisecond and velocity time integral in centimeters. Conventionally, aortic stenosis has been classified to mild with peak gradient up to 50 millimeters of mercury, moderate with peak gradient between 50 to 75 millimeters of mercury, and severe with peak transvalvular pressure gradients above 75 millimeters of mercury. But gradients depend on flow, and low flow severe aortic stenosis with low gradients have been described. Low gradients can also occur in the presence of severe left ventricular dysfunction, which improves after treatment. There is a good correlation between Doppler-derived mean gradient and cath-derived gradients in aortic stenosis. A peak Doppler velocity of 4.5 meter per second or more and mean gradient of 50 millimeters of mercury or more has a high specificity above 90% for severe AS with cath-derived aortic valve area of 0.75 square centimeter or less. But the sensitivity of these measures was low, below 50%. Doppler echo estimates peak instantaneous gradient, while cardiac cath estimates peak-to-peak pressure gradient between the left ventricle and the aorta. Moreover, in critical aortic stenosis, Carabello effect can induce errors in the assessment of gradients because presence of the catheter itself increases severity of the orifice narrowing. Phenomenon of pressure recovery can also cause a difference between cath-derived gradient and Doppler-derived gradient in aortic stenosis. Pressure recovery is the increase of downstream pressure in AS due to reconversion of kinetic energy into potential energy. When pressure recovery is present, Doppler estimated gradients will be significantly higher than cath-derived gradients. Discussion on discordant grading of severity of aortic stenosis or discordant AS. Discordance between various measures of severity of aortic stenosis is considered as discordant grading of severity of aortic stenosis or simply as discordant AS. Severe aortic stenosis has aortic Vmax more than or equal to 4 meters per second, mean gradient more than or equal to 40 millimeters of mercury, and effective orifice area less than or equal to 1 square centimeter. Peak aortic velocity and mean gradient are flow dependent measurements, while effective orifice area and Doppler velocity index are relatively flow independent. About 20 to 30% of patients may have discordant measures of severity of aortic stenosis on echocardiography. Discordance is mostly between effective orifice area and Vmax bar Doppler gradients. Low gradient and Vmax may occur with small effective orifice area. So the usual discordant AS has effective orifice area less than or equal to 1 square centimeter and mean gradient less than 40 millimeters of mercury. Low flow, low gradient severe aortic stenosis has low stroke volume with stroke volume index less than 35 ml per square meter body surface area. Low stroke volume index can occur with reduced left ventricular ejection fraction or with preserved ejection fraction. Lower stroke volume index is associated incrementally with mortality in low gradient severe aortic stenosis with preserved ejection fraction. Most frequent cause of low gradient aortic stenosis is a low left ventricular outflow state. This could be due to reduced left ventricular ejection, which is the classical low flow, low gradient aortic stenosis. When there is low flow with preserved ejection fraction, it is paradoxical low flow, low gradient aortic stenosis. There is a third category of normal flow, low gradient aortic stenosis with small aortic valve area as well. To differentiate between true severe aortic stenosis and pseudo severe aortic stenosis, two investigations are useful. Low dose dobutamine stress echocardiography is useful in classical low flow, low gradient aortic stenosis with LV ejection fraction less than 50%. Aortic valve area increases as stroke volume increases with dobutamine in pseudo-severe aortic stenosis, but it may not be useful unless the left ventricular stroke volume increases by 20% or more. Aortic valve calcium scoring and multi-detector computed tomography are useful in case of low flow, low gradient and normal flow, low gradient aortic stenosis. A calcium score above 2000 in males and 1250 in females suggests the presence of true severe aortic stenosis. In general, low flow, low gradient severe aortic stenosis has worse outcome following aortic valve replacement compared to those with high gradient. Still, there is a survival benefit with AVR. There is also a suggestion that transcatheter aortic valve implantation may be superior to surgical AVR in this group. Patients with low flow, low gradient aortic stenosis have higher late gadolinium enhancement on cardiac magnetic resonance imaging, suggesting more myocardial fibrosis. This is in comparison with high gradient aortic stenosis. But this was found irrespective of the flow reserve documented by dobutamine stress echocardiography. While measuring left ventricular outflow tract for the continuity equation, measurement is better taken at the level of the aortic valve annulus rather than deeper into the LVOT. Velocity and gradient should be sampled from multiple windows like apical, right sternal border and suprasternal notch to avoid underestimation, which can occur in up to 50% of cases. If the data are discordant even after these careful measurements, hybrid imaging may be considered to better define the alveotic cross-sectional area. These include three-dimensional echo and contrast-enhanced computed tomography. Discussion on eccentricity index of bicuspid aortic valve. This mode echocardiogram shows eccentric aortic valve closure in diastole. Systolic opening of the valve is good. Eccentricity index for a bicuspid aortic valve is calculated as follows. Half of aortic lumen diameter divided by minimum distance of diastolic cusp echo from nearest aortic margin. In this image, the diastolic diameter of the aorta is represented by A. Half of it is taken for the calculation of eccentricity index. B represents the minimum distance of diastolic cusp echo from the nearest aortic margin. In the study by Nanda and colleagues, the eccentricity index was low, that is 1 to 1.25 in tri-leaflet valves. Eccentricity index ranged from 1.5 to 5.6 with mean of 2.43 in those with bicuspid aortic valves. Central closure line of the aortic valve in a tri-leaflet valve is shown here for comparison. If the eccentricity index is calculated for this tri-leaflet valve, it will be close to 1. Two-dimensional image with bicuspid aortic valve in open position is shown here. Color Doppler echocardiogram in calcific aortic stenosis. Echocardiogram in parasternal long axis view showing calcific aortic valve which domes in systole with restricted opening. The aortic orifice is quite narrow. Normally, valve leaflets will almost be invisible in systole as they will get opposed to the walls of the aortic sinuses of Valsalva. Diastolic frame in aortic stenosis from parasternal long axis view showing aortic valve in closed position and mitral valve in open position. The marker is indicating the anterior mitral leaflet. Dense calcification of aortic valve is evident. Color flow mapping from parasternal long axis view in aortic stenosis shows the domed aortic valve with narrow aortic orifice and a mosaic multicolored jet beyond the aortic valve indicating turbulent flow due to the stenosis. Note that left ventricular cavity is quite small in systole due to the hypertrophy. Still image from parasternal long axis view with color Doppler showing the AS jet beyond the domed and densely calcified aortic valve. Calcific aortic stenosis in parasternal short axis view showing 3 leaflets. Dense calcification is visible. Still image in parasternal short axis view in calcific aortic stenosis showing 3 leaflets in open position, that is systolic frame. The markers show the leaflets. The commissure between the left and right coronary cusps appear fused and thickened. RVOT, right ventricular outflow tract, PA, pulmonary artery. Parasternal short axis view at the level of the aortic valve showing the aortic valve in closed position with significant thickening and calcification. The valve appears tri-leaflet rather than bicuspid. Apical 5-chamber view showing the thickened aortic valve. This is the usual view used for estimating transvalvular gradients as the Doppler beam is parallel to the jet in this view.
Another view used for estimating the gradient is the suprasternal view, especially when associated mitral regurgitation gets picked up by the Doppler beam, giving a falsely high gradient from the apical 5-chamber view. Still frame from apical 5-chamber view showing 4 cardiac chambers and the aorta with calcified aortic valve. The interventricular septum can be seen thickened as part of the left ventricular hypertrophy. Color flow guided evaluation of aortic stenosis jet from apical 5-chamber view with continuous wave Doppler interrogation. The upper panel shows color Doppler image and the Doppler line. The color bar at the top right shows the Nyquist limit of the color flow mapping system, 60 centimeters per second in this case. The lower panel shows the tongue-shaped envelope of valvar aortic stenosis. The peak velocity in this case is 2.97 meter per second, which corresponds to a gradient of 35.2 millimeters of mercury.
Discussion on rheumatic aortic stenosis. Aortic stenosis in rheumatic heart disease seldom occurs alone, but in combination with aortic regurgitation or other valvular lesions. Isolated aortic stenosis is most commonly congenital in young age group and degenerative in elderly. In severe aortic stenosis, the left ventricle hypertrophies as a compensatory mechanism. The type of hypertrophy is known as concentric left ventricular hypertrophy. In concentric hypertrophy, there is thickening of the left ventricular wall without enlargement of the left ventricular cavity. In late stages, as the left ventricle fails, it may dilate. Important symptoms of aortic stenosis are effort angina, exertional dyspnea, and exertional syncope. Effort angina occurs due to the mismatch between coronary arterial blood supply and the demand of a hypertrophied left ventricle. Exertional syncope occurs due to fixed cardiac output. When there is peripheral vasodilatation with exercise, the fixed cardiac output causes cerebral hypoperfusion and syncope. Important physical findings of aortic stenosis include a slow rising low volume pulse, pulsus parvus et tardus, heaving apex, sustained and forceful, soft aortic component of second heart sound, ejection click, and an ejection systolic murmur in the aortic area. The murmur of aortic stenosis is conducted to the carotids and may be associated with a thrill in the aortic area. It may be necessary to feel inhaled expiration to feel a less prominent thrill. Ejection click of aortic stenosis is non-phasic with no significant variation with respiration. Echocardiogram from parasternal long axis view showing thickened and doming aortic valve in severe aortic stenosis, dome Davy. RV right ventricle, IVS interventricular septum, LV left ventricle, MV mitral valve, LVPWO left ventricular posterior wall, LA left atrium. Left ventricle is hypertrophied as evidenced by the thickened interventricular septum. Severe symptomatic aortic stenosis can be treated by aortic valve replacement either with a mechanical prosthesis or a bioprosthetic valve. Recently, transcatheter aortic valve implantation or TAVI, also known as transcatheter aortic valve replacement or TAVR, has been introduced as a novel therapy. This approach is growing momentum, though a bit expensive currently. TAVI has been done mostly for the degenerative aortic stenosis of elderly than rheumatic aortic stenosis. Surgical repair of rheumatic aortic stenosis is another option in view of the long-term problems of a prosthetic valve in young persons. Various procedures described are decortication or peeling of the rheumatic thickening, shaving off and thinning the valve, commissurotomy, and decalcification. Repair may be considered for mild to moderate aortic lesions during concomitant mitral valve surgery with acceptable results. Repair can also be considered in young persons where the cumulative long-term problems of a prosthetic valve is more. Any procedure has to be done before the left ventricle starts dilating due to irreversible fibrotic changes in the left ventricular myocardium. But since AS is an afterload mismatch condition, the chance for improvement is more than in AR of corresponding severity and left ventricular dysfunction. In AS, the left ventricle has a chance of recovering once the afterload mismatch is removed. A report of 30 patients with rheumatic aortic stenosis in patients less than 30 years presenting with associated mitral stenosis has been published. 3 of the patients had additional tricuspid stenosis. History of rheumatic polyarthritis was given by 28 patients. Interestingly, the murmur of aortic stenosis was absent initially in 8 of the 10 patients who presented in congestive heart failure. All the patients underwent cardiac catheterization. Cine angiography showed tri-leaflet aortic valve, unlike in congenital aortic stenosis. Raised pulmonary vascular resistance was found in 87% patients.